Good morning, ladies and gentlemen. Let me start with a thank you to the organizing committee of UPASICON and UPASI for the invite for this talk in front of you here today. We're talking about eTEP or extended view TEP in context to repair of the inguinal hernia. eTEP, a 9-year-old 2012 to be more exact, entrant in the armamentarium of the laparoscopic abnormal hernia surgeons. Agreed that level 1 evidence still does not exist in its favor, but after the initial hesitation, a lot more number of surgeons like me are shifting to eTEP for the inguinal hernia repairs. But there has to be a reason for the growing acceptance, and that is because it's only the access which differs from the standard TEP approach. It's not a difficult approach to learn with only a little bit of additional anatomical knowledge. The rest of the PP dissection is identical to as in a standard TEP repair. So what is this additional anatomical knowledge required for the eTEP approach? It is understanding the patient's rectus sheath. What about the rectus sheath? You have to identify on the surface of the abdomen the lateral edge of the rectus sheath as the semilunar line of Spitzel, extending from the 9th costal cartilage right up to the pubic tubercle, and it is a curved line which forms the lateral edge of the rectus sheath. The posterior rectus sheath extends caudally and ends at the arcuate line of Douglas. The two facts which are important in the understanding of eTEP. The next thing that we have to understand is the distance of the semilunar line from the midline. And if you look at the distance, it varies from Zipfi sternum down to the pubic tubercle, to the pubic symphysis. And in and around the umbilicus and supraumbilical region, it is roughly about 6.8, about 6.5 to 7.5 centimeters from the midline. This is fact number one. Number two, the depth of the rectus sheath is also important. Normally, it is about 10 millimeter thick, but it can vary up to 20 millimeters, especially in those individuals who have got an increased rectus abdominis mass. Like, for example, those who have a six-pack, or they are heavy manual workers, or they are athletes. Now, the deeper surface of the posterior sheath, behind the posterior sheath, is again important. It is lined closely opposed to the underlying transverse fascia, underneath which you got the deeper peritoneum. A fact which is very important because even the slightest amount of trauma to the posterior rectus sheath is liable to injure the peritoneum, and that will lead to a troublesome pneumoperitoneum. The other thing about the rectus sheath is the content of the rectus sheath, and that is the inferior epigastric artery arising from the mid-inguinal point and at the mid-inguinal point, and then obliquely climbing up and over the arcuate line, entering into the rectus sheath and more towards the lateral part. Now, during its course inside the rectus sheath, it is about 4 to 5 centimeters from the midline. And number two, it is closely associated or stuck to the undersurface of the rectus abdominis muscle. Now, armed with these two facts, the first port is then positioned. Now, to remain inside the semilunar line and to prevent injury to the inferior epigastric artery, the port transversely should be somewhere around 3 to 5 centimeters from the midline. And the cranial extent of the first port is again about 3 to 5 centimeters supraumbilically. But when you're taking 3 to 5 centimeters, care has to be taken about this distance D, that is the port and the subcostal distance, because the subcostal margin is the bony margin, and if it is too short, then the instruments which are inserted to the first port would be clashing or would be hampered by the movement will be hampered by the subcostal margin. So it is this distance has to be adequate enough. Having said that, this first port, so that is the preferential position for the first port, 3.5 centimeters from the midline and 3.5 centimeters above the transumbilical plane. Now, having said that, there are other sites where you can put the first port, and that is any site medial to the semilunar line right up to the infraumbilical area, or it can even be beyond the semilunar line. But then these sites are those which would not be good ergonomically when you do the dissection. And that's why the preferred site is what we have just now defined. The third point about this port placement is the side of the placement. And it could either be ipsilateral, meaning thereby that if you got a left hernia, the first port is on the left side. If you got a right hernia, it is on the right side. Or it could be contralateral, that means a right hernia being approached by a left-sided first port. I normally use a contralateral first port side. It gives me more length ergonomically, intracorporeal length ergonomically. Now, the first incision is 1.5 centimeters. The skin is separated, retracted, the subcutaneous tissue is retracted until you reach the anterectal sheath. Once you reach it, you give a transverse incision, raise up the inferior flap, raise up the superior flap. That's the inferior, that's the superior, with the help of LE forceps. Once you do that, the rectus abdominis longitudinal fibers come into view, separate them with a blunt dissector, and you have the posterior rectus sheath in front of you. That is the posterior rectus sheath, more delineated with the help of two half-inch Deaver's retractors. These are the half-inch Deaver's retractors that we normally use. Now, this is a more better picture of the same thing, magnified, and you find that this Deaver's, which is applied over the lower lip or the lower flap of the rectus abdominis, lifts up that particular lip, and it also lifts up the two edges of the rectus abdominis muscle. Thus, you can see the starting of the retrorectus tunnel out here. So these are rectal fiber, and you can easily see what we are talking about. Now, once you delineate the retrorectus fiber, now you push in either a blunt trocar, or you push in a dilating balloon, or you push in your telescope. And that can easily go parallel. It has to go parallel to the rectus abdominis. It has to go parallel to the posterior sheath of the rectus abdominis, rectus sheath, posterior sheath. It has to be parallel to it, and it can reach right up to the end of the pubic symphysis. Now, once you have done that, then in that same track, you can now insert the sheath of the 10 millimeter port as we normally do. Now, this movement of the sheath should be absolutely trouble-free. It should be a smooth insertion of the sheath. Now, when you're going through the fibers of the rectus abdominis and reaching just up to the rectus sheath, this is the retrorectus space, what we were just not talking about. So it travels horizontally parallel to the anteabdominal wall. That should be the course should be taken by your dilator, or the trocar or the balloon dilator, until you reach the arcuate line. Once you reach the arcuate line, that is the site where you have a fusion of the transalus fascia and the arcuate line, so to say. So you transgress the transversal fascia out here and then enter the prepectoral space as shown out here. So once you have done that, there's transalus fascia cut out here, and now the retrorectus space and the prepectoral space becomes one single continuous flowing area. That gives a very, very large prepectoral space to play about with, and it is very, very ergonomically viable. You have a lot of intracorporeal length. So when the telescope goes in, the first view which comes is the loose cobweb tissue, which is the preperitoneal tissue, and you have the glistening of the posterior rectus sheath, more defined until you go transgress the transalus fascia here and you enter to the prepectoral space. So that's the prepectoral space. This is a sharply demarcated arcuate line, and here you have the loose retrorectus tissue. As you dissect further, then you find that the inferior epigastric artery is climbing up, and it is closely applied to the undersurface of the rectus abdominis muscle, which is forming the roof of the retrorectus tunnel. So that is the roof, and the retrorectus tunnel, the floor is formed by the rectus sheath, the posterior rectus sheath. More dissection, and you find the branches coming out from the inferior epigastric artery and supplying the rest of the rectus sheath. Now, in this case, as opposed to this, you find that there are three arcuate lines out here. So what is this all about? Let's see this. The arcuate line variations could be three in number. In one, you can have a gradual disappearance or merging of the posterior rectus sheath with the transalus fascia. So you will not find a sharply demarcated arcuate line as is seen in this patient. This is basically a cadaveric specimen. And this is unfortunately present in 65% cases. Why unfortunate? Because there you have to decide where to enter or where to transect the transalus fascia. Type 2, which is a sharply demarcated arcuate line, is present in only 25% of cases, and the multiple arcuate lines or the multiple thickened eponeurotic lines in the posterior fascia, known as multiple arcuate lines, is seen only in 10% cases. So why this all importance attached to the arcuate line? We already talked about the posterior sheath, we know that. Why the arcuate line? Because identifying or locating the position, which could be anywhere infraumbilically, right from the upper 1/4 of the umbilicus down even up to the pubic symphysis in certain cases. but more commonly it's in the upper half of the pubic of the umbilico-pubic distance or the extent. So you have to define that arcuate line, and that first time entry into the preparator space attempted after transecting the transalis fascia at the arcuate line. Number two, it defines the site for cutting the lateral and medial lower edge of the posterior sheath to enlarge the created to PP space or the preparator space. Now comes the time when you've done all this. Now is the time to insert the second and the third port. You don't insert the second and third port before this. Now, again, as we saw in the first port, here also it is very, very variable positioning of the second and the third port. Number two, it has to be always inserted under guided vision, and it has to be a guided insertion. What do I mean by guided insertion? You first push in the needle, the hypodermic needle, at the proposed site. See this needle for the second port, and once we find that it's not, it's within the semilunar line, it's not going through the posterior sheath, then we push in the trocar to that particular area. Similarly, for the umbilical port, you also push in the hypodermic needle, and once you push it in, only then you push in the trocar. So it has to be a guided. And you have to be very, very careful, because this is the time, the second and the third port, especially the umbilical port, when the posterior sheath is very, very easily damaged. And once you damage it, you go through the sheath, you create a pneumoperitoneum, which happened in the early cases with me also. And even those who are early entrants into this field, you have to be very careful at this point and at the point of first insertion of the first port. Now, the sides of the umbilical port could be either on the side of the first port, or it could be on the contralateral side, or the umbilical port can also be taken to the contralateral iliac fossa. So there are three sides to this umbilical port, either ipsilateral, contralateral, or in the iliac fossa. And the third port, or the second port, as you would like to call it, is at the contralateral iliac fossa. So that is now completed your three ports. Now, once that is done, the further dissection now proceeds. It's a very, very short video to show you the self-explanatory for the subtitles in it. This was 3.5 centimeters, 3.3 to 5 centimeters here. And the sheath coming into view, transected, enlarged, transection enlarged, lifted up with the help of LE. You can see the rectus fibers, separated bluntly. Posterior sheath has come into view now, putting the retractors on either side. Posterior sheath can clearly be seen, lifting the sheath up, and see it being passed horizontally, almost horizontally, the blunt trocar. And once you've done that, now I'm pushing in the sheath again horizontally. It should be a free movement, absolute free movement. Now, once carbon dioxide pneumoperitoneum, you can see it being raised. The one part of the sheath will be raised. That confirms you in the right space. And now fix the sheath, and that the first we were talking about, that is the preplate, is the transalis fascia underlying the undersurface of the rectus muscle. And now we're entering into the preparator space, the lighthouse, preparator retius space, clearly demarcated with a dissection with the telescope. Then needle guided second port, and you can see the incaping gastric artery there. Remember, this video is running at 2 times the normal speed. Now comes the time when you have to separate the peritoneum from the undersurface of the posterior sheath with the help of blunt dissection. Why? Because you want to enlarge the preparator space. So once you separate it, with the help, I normally use cautery, hook cautery to enlarge it. Care has to be taken about this distance. Remember, this distance, the medial distance from the linea alba is very important. You have to keep it at least more than 2 centimeters. Why? So that you don't damage the linea alba. If you damage the linea alba, you're going to create problems for the patient and for yourself with greater development of either divarication or development of hernia. Now, the umbilical port now being pushed in, again guided by the needle that I just now showed you in the last slide. And now you will carry out the two grasper dissection. The space of Bogros being dissected. This is the cord, and you're going lateral to the cord, so that's space of Bogros. The peritoneum being stripped of the undersurface of the abdomen. That dissection has to be very careful. And then now the reposition of the condyle sac, which is the direct sac. You can see the transalis fascia, loose transalis fascia of the sac, and the condyle sac being brought down. Once you bring it down, the space of retius brings into view, the whole of it, and you have the pubic tubercle in front of you. Now you have to strip the peritoneum of the cord structures with the help of sharp, blunt, and cautery dissection. Strip the peritoneum of the psoas fascia laterally, strip it proximally, and then more medially of the vas deferens until it goes medially. So all the stripping has to be done. Once that is complete, you push in either 10 to 15 polypropylene mesh or a 12 into 15 polypropylene mesh. I normally roll it as a cigarette. I don't apply any sutures, and if it is self expanding, then the space creation has been adequate enough. One tack to be applied just above the bone, taking care that the medial and the other is at the upper outer angle. You have to take care that the positioning should be such that the medial end of the mesh should go beyond the pubis symphysis on the contralateral side. Now, so seeing this picture, I think it will be very evident about the advantages. Seeing this short video, the advantages of the eTEP approach, the flexibility in positioning of all the three ports. Number one. Number two, the preperitonial space and lower abdominal wall becomes so huge, results in a very large opened up PP space, and that large open PP space gives a better maneuverability of the instrument, very good ergonomics. Larger mesh can be placed, better tolerability of pneumoperitoneum. Even if pneumoperitoneum develops, you don't have to worry. In a routine TEP, it becomes so worrisome and problematic that doing further dissection becomes really problematic in those such instances. It allows unencumbered proximal dissection of the sac and the peritoneum. So thus, eTEP is easier to learn and master. It is very, very evident after you're doing done only 3 or 4 cases, you become so proficient doing it. You're so happy with it. It should become a good starting point for residents to learn the TEP repair. So with all these advantages, it is self-evident that the additional indications which were not there for TEP now work for the eTEP. Thus, you can even approach large inguinal scrotal sliding or incarcerated hernias. You can approach obese patients because the abdominal wall is thinner supraumbilically and hence easier first port insertion is there. Post-bariatric patients, patients with a short pubo-umbilical length, and of course in patients with previous pelvic surgeries and with infra-umbilical scars. Do I need to conclude? Isn't it obvious? We have an inquisitive surgeon who's wondering what this is all about. He sees a couple of procedures being done in a workshop or elsewhere, and he's now indecisive whether he should go in. Once he decides, he goes in, and after a few procedures, he's such a delighted person that he shifts, as I did, from TAPP. Now almost equal eTEP and TAPP have stopped doing TEP repairs. Thank you for your time. For the full video of the clip that I just now showed, you can see the full video and other instructional videos and lectures on laparoscopic and general surgery. You can see them on my YouTube Prime site, that is Rajiv Sinha JHS, or else you can visit my website, and through that you can approach the YouTube site where all these videos are loaded. Thank you once again.